See it?
Looks good, yes.
Okay, great. So I'm Dr. Tiongson. I am a general neurologist, so I'll see, all aspects of neurology. I work primarily outpatient. I work both at Morningside and the main campus. And I also do some time inpatient at the main campus as well with the residents. So I'm just going to talk to you a little bit about primary headaches and management, and I'll also get into a little bit of the secondary headaches as well if we have time. But I was told to primarily talk to you about the major primary headache disorders. These include migraine with and without aura, tension type headaches, as well as trigeminal autonomic cephalgias, which the most common one that you're familiar with is cluster headaches. So these are the ones I'm primarily going to focus on. In particular, migraine headaches, I'm going to spend a large portion of the time talking about migraines. They're very prevalent. It's the most common reason to see a general neurologist. Practically everybody knows someone with migraine. 1 in 4 households have someone with migraine. A good 12% of the population. It does tend to affect women more than men, with women making up 85% of the people with migraine. And it also does affect children as well. The most common age affected does tend to be 18 to 44. And it is, I'll often describe migraines as somewhat of a genetic disorder, that, people have a genetic predisposition towards developing these kind of severe headaches. And you'll find that a lot of people with migraine also have family members with migraine. But sometimes they won't actually know it's migraine because a lot of people will kind of push it aside and just be like, oh, these are just headaches. Some of the pathophysiology about migraine, it's often described as what they call a cortical spreading depression, which is just involves, kind of a propagating wave of polarization across the cortex. The primary parts that are involved tend to be the trigeminal afferents, so you'll find that a lot of people with migraine will complain of a lot of pain right in the forehead region, as well as like the eye. A lot of people will even say, there's something in my eye, I can feel it, but 99% of the time you'll image them and there's nothing there. It's just part of the pathway of migraine. A lot of times these pathways kind of feed off of each other. So often the trigeminal nerve will also interact with some of the projections from the upper cervical nerve roots. So you'll also have patients kind of report pain that starts in their eye and kind of shoots backwards to the back of their head. So you'll often see that a lot of people will have pain in like cervical regions, including the back of the head, as well as the neck. And then, stimulation of these pathways often results in the release of various neuropeptides, including substance P, calcitonin gene-related peptide, which has changed treatment a lot, and some other neuropeptides. So Cgrp is a potent vasodilator, and has, the research on Cgrp has significantly changed the treatment profile. So we'll talk a little bit about the treatment options that involve that pathway later on. So the criteria for migraine, it's actually pretty easy to meet criteria. At least 5 attacks, somewhere between 4 to 72 hours untreated. If someone says that they have a severe headache that gets worse with activity and is associated with nausea, technically that will meet criteria for migraine. If you have nausea, you automatically do not have tension type headaches, because nausea is not considered part of a tension type headache. Other textbook kind of descriptions of migraine are going to be unilateral, throbbing, pulsing pain, often very severe, as well as, you only need either nausea or photophobia or phonophobia to meet criteria. And of course, you don't want it to be due to anything else. And this is specific for migraine without aura. I'll talk about migraine with aura a little bit later. They also divide it into episodic, chronic. So basically the magic number is 15. Less than 15 is episodic. 15 or more is chronic. And that just changes a little bit about what you can get through insurance probably. And status migrainosus is just a headache that's lasting more than 72 hours. So there's actually multiple stages of migraine. So a lot of people will start to feel like their migraine coming on 24 hours beforehand, but they won't really recognize it as such. Actually, like a large percentage, 77% of migraine patients have a prodrome, and this could be yawning, depression, irritability, cravings. I have quite a few patients that tell me that they know their migraine is coming on when they get this like neck pain. They're like, okay, if I get this neck pain, I know that my migraine is going to come later. And then the next stage is potentially aura. Not everybody has an aura. Only about a quarter of patients have aura, and they don't always have aura. And you know, the most common kind of aura that people have is visual. And these visual auras can often be alarming. You'll often find that patients who have their first aura will go to the ER or urgent care or something like that, because it can be quite disturbing. Like it could appear as like zigzags. Here you see a couple of examples of migraine auras that people have had where it's like kind of like the peripheral vision is kind of shimmery. Sometimes other people get just like kind of like a shining, shimmering quality. Different people see like rainbows or zigzags. So it does tend to be more positive. Some people can have like vision loss, but that's not as common as the more positive symptoms where you actually see things that aren't really there. But when you start to have the negative symptoms like vision loss, that's when you have to make sure it's not something more concerning like a stroke. You can also get sensory auras where it often be a tingling sort of sensation. Once again, a positive sort of sensation. So the tingling often tends to be a traveling sort of tingling. It'll start in one area and progress to involve the arm and the leg. So it does tend to also be unilateral. Some people will even get speech problems where they'll have trouble speaking, trouble reading. Once again, you know, if you do have to rule out stroke in these kind of scenarios. And then there's also the famous familial hemiplegic migraine where you'll actually get unilateral weakness. You'll also find that some people won't get their auras until after they're 50 years old. Like there's some people who will start to have visual auras like later on in life, but won't necessarily have it when they're younger. So migraine with aura, you know, it involves having, you know, one of these sensory phenomenon that has to be fully reversible. Some people even get sort of vertigo type auras as well. And then the aura usually tends to have different durations, but it usually is like somewhere between 5 and 60 minutes, and then it'll be followed by or accompanied by the headache. So in order to meet migraine with aura, you need 3 of the following. So if you have, you know, visual aura that lasts for 5 minutes, and then you get a headache where it's like shimmering lights, that meets criteria if you've had 2 attacks. Or if you've had like multiple kind of symptoms at the same time. So I had one patient the other day who got the tingling of the arm and then reported that her vision became watery. And then she had a headache subsequently afterwards. The headache itself lasts, you know, 4 hours to days. It tends to be unilateral throbbing, but a third of people will report that it's on both sides. Some people will feel like they're being hit with like a baseball bat. Some people will describe some pretty severe symptoms. And as we mentioned, nausea, vomiting, photophobia, phonophobia. Some people will even get like tenderness where it's like if they touch their head, it's painful. Often these headaches are very debilitating. People aren't really able to focus on what they're doing. And they'll often report that they want to go to a dark room, turn off all the noise, and just go to sleep. And often sleep is the choice that people want for migraines. Like they'll want to sleep to make it better. And then there's potentially a post-drome, like for particularly bad migraines, people will feel like kind of out of it the next day, like tired and just sort of not well. It can have a recovery period. So, one of the first things that we focus on is like asking patients what makes their migraines come on and what makes their migraines worse. And this helps us kind of determine what lifestyle modifications, since lifestyle modifications are a very important part of migraine management. So we often talk about sleep. Do you get enough sleep? Is it a restful sleep? Do you snore? Do you wake up tired? So, I mean, if you're only sleeping, 4 hours a night and you're waking up fatigued, obviously, and you're getting a lot of headaches, then sleep has to be an issue. If you're getting 8 hours, but you're still waking up fatigued, maybe you snore at night. So I have, often it's not uncommon for me to recommend sleep studies for patients who have migraines. Like I've had some patients who they will respond to some degree to the migraine medications, but I've had patients whose headaches got completely eliminated once they started using CPAP for their sleep apnea. I've also had other patients who told me that melatonin was all they needed, and that cured their migraines. So sleep is very important. Other things to talk about are food and drink. So of course you have to eat regular meals, you have to stay hydrated. There's a list of foods that are reported to be relatively common triggers. And this is extremely variable. Like some patients, none of these foods have any effect. And then there's some patients who will get a headache every time they, for example, drink red wine, eat a piece of chocolate, eat a piece of aged cheese. One of my patients actually, like she said she went to a party where she ate a bunch of aged cheese and she had a 2-week migraine afterwards. And she was wondering why it happened. And it's possible that it might have been that aged cheese. Some things that you don't think about are like citrus fruits. I had one patient also with cold cuts. She gave up cold cuts and then stopped having migraines. So it is important to try to figure it out. Of course, stress is always a factor. They've actually found that, mindfulness, meditation, cognitive behavioral therapy sometimes help with migraine. And exercise has actually been in some studies, particularly aerobic exercise is similar to medications in controlling migraine as a preventative. During the pandemic, there were a lot of people who kind of stopped exercising because they couldn't go out to the gym or they didn't want to go outside. And then some of them actually subsequently developed migraines. And then when they returned back to exercise, they stopped having them again. So seems like, it surprises you how many things really do affect how much you have a migraine. Other triggers that some don't necessarily have control over. So some people have menstrual migraine. You'll find that in women, they'll often say that in their 20s, that's when their migraines kind of are really bad. And then it'll kind of get better in their 30s, 40s sometimes. And then right around menopause, the migraines kind of come back, not necessarily in the same way, but those are the high points of migraine frequency and I guess the timeline for a woman. Other things that you have to keep in mind are things like birth control. They might have effect, in particular estrogen. But I have had patients who developed headaches, with some of the IUDs as well. As far as the weather, you can't really control that, but you will have some patients who tell you that, when it's really hot, they'll get it. Or when there's a major rainstorm, they'll know it's coming because they'll have a terrible migraine. Other people will just report lights or smells. Often you'll find that screen time is often an issue. Like a lot of people, because of all the working from home, I will recommend like blue light blockers to a lot of people, but it's not really it's not been shown in evidence that they work, but I do feel like it does make some benefit for some patients. So as far as the treatment options, there's a lot of treatment options. So there's two types of main medications that we use. There are the abortives, which you take as needed, and then there's the preventatives, which you take every day. So I'll go into a little bit of the details. So I mean, probably a lot of you have seen the neurologist inpatient use a migraine cocktail. So if somebody comes to the ER and you need to get rid of their migraine because it's so bad, a lot of times we'll do a migraine cocktail of sorts. On the left side, I guess is kind of the easier things to use, Tylenol, Toradol, Reglan. I read that Benadryl and IV fluids don't really have that much evidence for them, but they're sort of benign anyway, for the most part. The fluids tend to work really if they're dehydrated, and often people don't drink enough water in general, so it's not a bad idea. If the things on the left don't work and there's, the patient still has headache, I'll consider some of the things on the right side. So magnesium, dexamethasone, Depakote, sumatriptan, if there's no contraindications. I'll even consider, some antipsychotics. Haldol and olanzapine actually do work well for migraine as well. So these are some of the things that are pretty good at breaking headaches. Some of the other ones, we've kind of mentioned some of the anti-emetics. So Reglan is an option, as well as some of the other ones like Energan or Tryptans are kind of our mainstay of treatment, but we have to keep in mind that these are contraindicated in several conditions, including, anyone who has coronary artery disease, anyone who's had a stroke, anyone who has uncontrolled hypertension. You certainly wouldn't want to do it if you were worried about someone having an aneurysm. Tryptans are vasoconstrictors, so they're going to kind of increase pressure. So they do work, but you have to be hesitant with them. Tryptans, there's various forms. There is the oral ones, but there's also injectable and intranasal ones that work a little bit faster than the oral ones. They have kind of a compound benefit with the NSAIDs. So I mean, NSAIDs you can use, and Tylenol, of course, you can use. But they actually made a combo medication where they combined sumatriptan with I think it was naproxen, because they have kind of a synergistic effect. Sometimes we'll use ergots like DHE, but these are also contraindicated for the same reason that triptans are. Sometimes we'll use things like muscle relaxants. Tizanidine in particular has an indication for migraine, but I'll also sometimes use baclofen. Furoset and Furanol you'll see used by a lot of people, in particular like the OBGYNs will use it a lot. That being said, it's not actually shown to be safe for pregnancy, and there's not really a great evidence to support its use. And they also, they can make you a little, it can kind of make you drowsy, but can also make you awake depending on which part you're more sensitive to. Opioids, we generally try not to use them at all if we can avoid them because of medication overuse. So these are the new medications. So both of these types of medications were actually just approved in 2020. And they have a lot of good advertisements behind them. Serena Williams advertises for Ubrelvy, and Khloe Kardashian advertises for Nurtec. So these are the Cgrp antagonists. So they bind the receptor and inactivate them. They don't, like the list of side effects here, that is like all of the side effects. Like usually, with most medications, you'll have a very long list of like, almost, 100 side effects, but this is literally like the entire list. So, and it's like a low percentage of patients who will report it, like less than 5%. So this is a major breakthrough, and we use these as needed, but Nurtec can also be used for prevention, and it just got that indication recently. The other option that we have is something called a Ditam. So it's similar to the Tryptans, but then they made it so that it doesn't have the vasoconstrictive properties that the sumatriptan has, or the other triptans have. So it's no longer contraindicated for cardiovascular risk factors, and that's the same for GPANs. The only thing about this one is that there is this issue with the drowsiness and the dizziness, and you're actually told not to drive under the influence of these drugs. So that kind of, I honestly haven't used it very much because of that reason. But if, I guess, you have a patient who's having trouble sleeping and they've tried other medications, this might be a good option potentially. So one thing that we have to keep in mind with all abortive agents, except for the Cgrp antagonists, is the possibility of medication overuse headaches. And this can occur with pretty much all of them, just depending on how many times a month you use them. So as a rule of thumb, I tell patients not to take more than 10 of anything, 10 days of anything. I mean, I think that you could probably get away with a little bit more with Tylenol and NSAIDs. But you'll find that if patients use medication every day, that it really gets harder to break their headaches. And I think in some rat models, like for triptans in particular, they'll find that the rat models, they'll have like higher sensitivity to pain in general, if they use too many triptans. So that's also why you have kind of the restrictions on how many triptans you can give in a month. So some other options that we consider for acute use are different blocks. So basically like lidocaine and things like that. So, sometimes we'll do occipital nerve blocks, palatine ganglion blocks, supraorbital or auriculotemporal. A lot of the headache specialists tend to do these. And then there's preventatives. So preventatives, you tend to use, if patients are having, either an excessive number of headaches per month, the headaches are lasting long periods of time, or if they're causing them significant disability each time that they have them. And the goal overall is to reduce their frequency, severity, duration. Also, when you're on a preventative, you respond better to your abortive agents. Also, if you're having, like, one of the worries is that you'll become chronic migraine and you'll even have even more headaches than usual. So these are more of the first line medications that are recommended for prevention. So you always have to try at least, 2 of these agents before you try some of the newer medications. So tricyclic antidepressants are often used, like amitriptyline. However, those have the side effects of like weight gain, constipation, dryness. So the serotonin norepinephrine reuptake inhibitors are also used, like Cymbalta, which is duloxetine, and Effexor, which is venlafaxine. A lot of anti-seizure medications like topiramate and valproic acid are used, but probably the anti-epileptic medications that we use have the highest rate of side effects. Gabapentin, I feel like a lot of us will kind of use gabapentin sometimes, but there isn't really great evidence for its use in migraine. The other group of medications are the antihypertensives, which, because they lower blood pressure, can cause some dizziness. The mainstay are the beta blockers, but candesartan you'll often find used for migraine as well. So if you have like patients who, also have high blood pressure, candesartan is a good choice to treat high blood pressure as well as migraine. There's some evidence for lisinopril, but honestly, when I've seen patients who are taking lisinopril, none of them seem to really report that much benefit from lisinopril for their headaches. Verapamil used to be commonly used, but when they, studied it, it doesn't seem like it's been that helpful. So the newer medications that we have are the Cgrp monoclonal antibodies. So Aimovig was the very first one. So that binds actually the CGRP receptor. The rest of the agents, Emgality, Ajovy, and VFD, they bind the actual ligand, CGRP. They have the body kind of eliminate these from the system. And then for them, what's great about these is they, really the only side effects are injection site reactions and allergic reactions, with the exception of Aimovig. Aimovig also can cause constipation, and they think it's related to the fact that it binds the receptor instead of the ligand. But the other great thing about these medications, there's not really many contraindications, and you don't really interact with any other drugs. Some people will use caution in giving them to people who have, cardiac risk factors and things like that, because we're getting rid of CGRP, which is supposed to be, a vasodilator. Is that going to affect, our bodies from properly responding to situations where it needs to vasodilate? That's sort of a question that we don't know the answer to. So far, we haven't really found anything that suggests that it's harmful, but, they've only been around for about 5 years or so we'll have to see. So these are, the first three are available as subcutaneous injections, which are all very easy to use. The Emgality one is kind of like Trulicity. Aimovig is kind of similar to some of the other medications that are given, like Praluent has the same injector. And then VFD is actually an infusion. So they'd have to go to either an infusion center or get a home infusion. And then the oral versions are Nurtec and Qulipta, which Qulipta actually just got approved maybe 2 months ago. And they can be used for prevention as well. So Nurtec is an every other day medication, and Qulipta is every day. So when those things don't work, then you start to consider Botox, but this is particular for chronic migraine, so you really have to have headaches 15 days or more. You'll notice that these areas where they inject the Botox are probably the areas where everybody who has chronic migraine experiences the pain. So right around the forehead and the eyes, the temples, the back of the head, and the shoulders. So other options that are sometimes used, I don't really use any of them too often, but they do have some benefit, clonidine, memantine. I had one patient who actually did not respond to anything but memantine. She had like the worst headaches of her life. And, I even tried Emgality. She tried Botox, but for some reason, memantine was the only thing that she responded to. I've had other patients who have refractory headaches respond to olanzapine. Olanzapine can also be a good abortive agent. They say that lamotrigine is really helpful for auras, but not as much the headaches. And then there's some other things. There's also many devices that they use for migraine. I think of all of these, I'm the biggest fan of the Cephally. Cephally is approved for use in pregnancy. It doesn't require a prescription, which is nice. So the only problem is really the cost. It's probably a $350 to $400 for the cost of the device, and then you have to pay for the electrodes on top of that. But it does have a 60-day money-back guarantee, so if it didn't work, they could always return it. There's also these other things like the Transmagnetic Stimulator over here, the Gamma Core, which is a vagus nerve stimulator, which I've had patients with refractory migraines respond to this, but it's always an insurance issue. And then there's the Neurovio, which you just put on your arm. Some alternative treatments. So some of the vitamins that are options. I'm a big fan of use of magnesium and riboflavin for migraines, because there's some patients you just give that to them and then it cures their migraines, and then that's it. And that's all you have to do. Some other options, Butterbur, the reason it's not recommended because it's not well regulated and you don't know if you'll actually accidentally have some substance that's actually bad for your liver. And then feverfew, melatonin, and CoQ10 have been shown to have some benefits for migraine as well. And then patients will also report benefit from things like biofeedback, cognitive behavioral therapy, and acupuncture. So now I'll move on to tension type headaches, which are mild to moderate, often more bilateral, dull, feel like a band or a cap, tend to be worse with stress, worse at the end of the day, after staring at a screen for a long time. A lot of times there'll be tenderness of the muscles, very specifically not associated with nausea, but can still be a problem since it can, this is more common than regular migraines and can still result in loss of work days. The criteria, kind of similar to what we discussed, was kind of like a bilateral type kind of feeling, mild to moderate, should not be aggravated by activity. So, I mean, you can have potentially some photophobia, but I mean, I guess you should not have photophobia either. Or you can have one but not the other. You can't have both. That's what. So then it's, there are different criteria on the frequency. So for treatment of this is kind of more your regular treatments like Tylenol, NSAIDs, aspirin. There are, when it does become frequent, then you still can use things like tricyclic antidepressants, topiramate. Gabapentin has more benefit for this than for migraine, as well as like physical therapy and behavioral changes, making sure you get enough sleep, making sure you drink enough water. Then there's the trigeminal autonomic symphyalgias. So, cluster is the most common. What happens is that it has to be one-sided autonomic symptoms. And those autonomic symptoms can be redness, drooping, tearing, ringing of the ears, even the pupillary constriction. The pain is usually very severe. Sharp, burning, like this is the kind of thing where patients are like, oh my gosh, I want to kill myself kind of pain. And then unlike the symptoms of migraine where you kind of want to go to sleep, go in a dark room, these patients tend to pace a lot more. They tend to go back and forth. This often can happen at night. Sometimes we'll call them alarm clock headaches. Can also be associated with nausea, vomiting, and photophobia. So what distinguishes the different trigeminal autonomic symphyalgias? It's mostly time. So cluster headaches are minutes to hours, and they can occur up to 8 per day, but they can also occur every other day. And then the SUNCT and the SUNAs are very short, but they can occur hundreds of times a day. And then paroxysmal hemicrania is somewhere in between. Cluster tends to be predominantly male, paroxysmal hemicrania tends to be predominantly female. And then the last type is called hemicrania continua, where you have continuous headache for months to years. And there's some variations in the treatment. I'm going to focus mostly on cluster since that's the most common. The other ones aren't too common. So you'll have at least 5 attacks of unilateral pain that we kind of described earlier, with the autonomic symptoms, potentially the restlessness, and it'll occur kind of in a cluster, either every other day or a bunch in a row. But there's going to be periods of it tends to have like periods where you have no headaches and then periods where you have too many. So, the acute treatment, I think we've all learned in like our textbooks that it's oxygen. You give oxygen. So if they come to the ER, you can give them oxygen. It's much harder to get oxygen at home. Triptans are useful, especially you want to use the fast acting ones, so the intranasal and the subcutaneous are faster. And then you might want to consider something like intranasal lidocaine or an ergot. The vagus nerve stimulator that I discussed earlier is also a potential treatment for acute symptoms. Preventatives are verapamil, topiramate, lithium, and different blocks. In particular, I do want to mention Emgality because it's the only medication I think that's approved for cluster of the Cgrp monoclonal antibodies. And I've had patients who, I had a patient who like had terrible cluster headaches, and this was the only thing he responded to was the Emgality. So it was really a lifesaver for him. Like he used to have like a ton of headaches, and the last time I don't really see him anymore because the Emgality kind of cured him. Other headaches I want to mention is trigeminal neuralgia, which is obviously another one of those kind of painful, terrible ones where you kind of want to kill yourself because the pain is so bad. It's usually seconds of like a shock-like sensation that can be aggravated by chewing, brushing your teeth, something cold. Tends to affect more often the lower areas like the jaw and the cheek, but can also affect the one area too. Sometimes it just happens and we don't have a good explanation for it. Some patients will develop it after some sort of dental procedure. You'll always image these patients, MRI with and without contrast, to make sure there isn't some sort of tumor. You also want to rule out MS for this patient because MS is trigeminal neuralgia is a presentation of MS. So the first line agents are carbamazepine and oxcarbazepine, but these agents, they can cause agranulocytosis and hyponatremia, so you have to monitor the labs for these patients. Second line agents, lamotrigine I've had a lot of success with. Gabapentin, you really have to use very high doses for it to do anything. And when things are refractory, you can refer them to pain management and neurosurgery to consider more invasive treatments. So the last thing I wanted to talk about were kind of the questions to ask about headache to make sure it's not something worrisome. Of course, you want to ask about the onset. Is it like sudden thunderclap sort of headaches? That's more of a red flag as opposed to one that kind of insidious onset where it just slowly comes on. Obviously, the greater severity, the more concerned you are. You'll want to ask about duration and quality. And you'll always want to ask if you've had headaches like this in the past. Sometimes patients won't, share that information unless you pry a little bit more. Associated symptoms, is there any nausea? Is there any vomiting? Is there any neck stiffness? Any trauma, medical history, family history of aneurysms. You'll also want to know about their family history of headaches, because as I mentioned before, migraines tend to run in families. Also, what they respond to also tends to run in families. Like if one family member responded to Emgality, their daughter will probably respond to Emgality. So what are the red flags? So worst headache of your life that's very sudden onset, you'll definitely want this patient to go to the ER. If it is worse when they're lying down and wakes them up from sleep, severe nausea, vomiting, severe neck stiffness where they can barely move their neck can be a sign of meningitis or subarachnoid hemorrhage, as well as if you have some sort of fevers or chills, that could be a sign of meningitis. And of course, if you have any associated neurological symptoms, double vision, weakness, vision loss, trouble speaking, and you want to have a little bit more caution when patients who are older present with new onset headaches. So this is sort of the acronym that people use to talk about red flags. The mnemonic is SNOOP. I don't really like it that much, but you're going to worry about whether or not they have HIV or malignancy, if there's any neurological deficits, if there's like a sudden onset, if there's some sort of change in the pattern, or if there's papilledema. You always get concerned in pregnancy because of the risk of cerebral venous sinus thrombosis. And then even for the trigeminal autonomic cephalogists, even if it's characteristic of those things, you do want to rule out like a patient who presents with like cluster-like headaches, you definitely need to image them to make sure it's not something else. Also, you need to evaluate for headaches that are induced by exercise or cough or sex, because that can be a sign of some sort of blood vessel abnormality or some sort of other issue. So imaging that you can consider, CAT scans are good for the evaluation of hemorrhage in particular. MRIs are useful for everything else, and angiograms you'll consider for aneurysms, and venograms you'll consider for venous sinus thrombosis. So the things that you don't want to miss are hemorrhage, meningitis, mass, venous sinus thrombosis. And I was going to talk a little bit about idiopathic intracranial hypertension and temporal arteritis, because you wouldn't want to miss these. So giant cell arteritis tends to be a temporal headache, older age. Sometimes you'll see a thickened temporal artery. Some things that you want to ask about are whether or not there's any jaw pain or sensitivity of the scalp. It does have an association with polymyalgia rheumatica, so they'll sometimes complain of like shoulder pain, and they might also have some systemic symptoms like fevers, chills, weight loss, malaise, decreased appetite. And the reason this is an urgent evaluation is because they can have vision loss if you don't treat it soon enough. So the treatment is just high dose steroids early, have them evaluated by a rheumatologist, and get a temporal artery biopsy. You can also potentially do ultrasound of the temporal artery, but that's a lot more user dependent. Another thing to keep in mind is idiopathic intracranial hypertension. So this is a positional headache, worse with lying down, and anything that increases the pressure. So if you bear down, if you bend, cough, sneeze, laugh, that makes your headache worse. You'll have to consider evaluating for this. And if you look in their eyes and you see swelling, you also want to evaluate for it. Other things that can be associated with these types of headaches are tinnitus or visual complaints. You get concerned about their peripheral vision, because that's the reason this is urgent, because you don't want them to lose part of their vision. Some of them will complain of double vision because of the sixth nerve is the most likely to get compressed with high pressure. So they'll often have horizontal double vision. And this tends to be associated with patients who are heavier and who have recently gained weight. So when you do the MRI, it may or may not show some abnormalities. In particular, you could see some flattening of the globe. Sometimes you'll see that kind of like this, the tortuosity of the optic nerve, as well as sometimes you'll actually even see some like swelling going into the orbit, into the eye. And then this is an empty cella. This is where the pituitary gland should be, but you can't see anything in there. There's nothing in this cella. These patients, you need to monitor their visual fields, and then the lumbar puncture with high pressure is diagnostic for them, assuming that their imaging is otherwise normal. So treatments include weight loss, Diamox, topiramate. If those don't work, sometimes you'll adjunct with Lasix, and if they're refractory to anything, you'll have to consider different surgical options. And that's it. Does anyone have any questions about anything? I know that was a lot.
Thank you, Dr. Tiongson. I see Raj, you have a question?
Yeah, thanks, Dr. Tiongson. I had a question that, we didn't speak about it in this lecture, but for like patients that come in to the floors that you know, typically seem to have like rebound type of headaches. They're always taking Tylenol at home. What's the best way to address those patients? You know, we want to avoid giving them like pain medication all the time. They're kind of complaining of just a generalized headache and they have like a history of Tylenol every day. But then as soon as we stop that, you know, that headache comes back. How would you address that?
I mean, sometimes it'll take a little bit of time. You know, one thing that we sometimes use in rebound headaches is like as an abortive that is less likely to cause rebound is like tizanidine. It does have an indication for use for rebound type migraines, and then also getting them on a preventative medication sooner. You know, in the acute setting, you'll probably just have to keep using the med, but the hope, I guess, is partially so that, you know, you reduce the amount that they'll need. Sometimes you'll need to use things like a migraine cocktail to kind of break the headache. So hopefully they wouldn't need a constant medication. So sometimes I'll consider things like that depending on the situation. Like a lot of times outpatient, if somebody has it, sometimes I'll consider like a steroid taper or something like that, like a Medrol dose pack. There's different options that you can consider doing. Is that helpful?
Yep, thank you.
Anybody else with a question? If not, I actually wanted to ask you, Dr. Tiongson. So we see very often that patients we refer to headache clinic as an outpatient, they end up getting imaging. So I wanted to know what your approach is for getting neuroimaging in a patient without any suspicion for a hemorrhage or a mass. Is there any data for or against which guides using imaging as in an outpatient setting?
So, I mean, often if patients have, I tend to image pretty liberally. Like if patients have some sort of major change in their headaches, then I will image them. You know, I will say that, you know, most of the time I don't find anything. And like, I don't really find anything unless there's like a neurological deficit or symptom or something like that. Most of the time it's fine. In particular, I will say like the very classic migraine symptoms, I never find anything. That being said, I usually, even if there's a change, I will tend to image to be on the safe side.